Mahesh sir.
Good evening. Good evening.
Arun, Mahesh ಅವರು ಲಾಗಿನ್ ಆಗಿದ್ದಾರಾ?
ಕಾಲ್ ಮಾಡಿದ್ದೆ ಮೇಡಮ್, ಲಾಗಿನ್ ಆಗ್ತೀನಿ ಅಂತ.
ಓಕೆ, ಇನ್ನೊಂದು ಅರ್ಧ ಮಿನಿಟ್ ಅಲ್ಲಿ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ. 7:29 ಆಯ್ತು, ಕರೆಕ್ಟ್ 7:30 ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬಿಡಿ.
ವೀಣಾ ಎಸ್ ಭಟ್ ನೋಡಿದೆ, ಅವ್ರು ಭದ್ರಾವತಿ ಅವರು ಕಾಣಿಸುತ್ತೆ.
ಓಕೆ, ಸ್ಟಾರ್ಟ್ 7:30. ಅರುಣ್.
ಮೇಡಮ್,
ಸ್ಟಾರ್ಟ್.
Good evening. Just a minute. Let me sit. Okay. ನಮಸ್ತೆ. ಎಲ್ಲರಿಗೂ ಹೊಸ ವರ್ಷದ ಶುಭಾಶಯಗಳು. The new year has brought in a lot of cheer and happiness and joy to everybody. We have just witnessed a very wonderful Karnataka State OBG conference being conducted at Bijapur, and we are back fresh from the memories of this conference and having met all the near dear ones there. I also now take the opportunity to heartily welcome you all to this another interesting program conducted under the aegis of KCOG. Good evening, one and all. Welcome Dr. M.G. Hiremat sir, the Chief Patron of KCOG. Welcome to Dr. Muralidhar Pai sir. Welcome to our speaker for the evening, Dr. Shripad Hebbar sir. I would also like to welcome our dignitaries in absence, Dr. Hema Divakar ma'am, Dr. Sajjan sir, and Dr. Vidya Bhatt, who are the chief dignitaries of the KCOG. And I also take this opportunity to welcome all the delegates who have logged in for this program. We know that respectful maternity care is now the call of the day, and we need to renew and remember that what we are going to do for those 12 to 24 hours in the labor room is going to determine the future of the patient in terms of our obstetric performance. For this important meeting, we have a very renowned professor of the very prestigious medical college whom we all look up to, that is the KMC Manipal, and I'm sure Dr. Muralidhar Pai would be very proud to have him, his own colleague, and students of Dr. M.G. Hiremat sir for addressing this gathering. I once again welcome you all for this evening session. Over to you, sir.
Okay. Good evening, everybody, and Happy New Year to all. We are coming with one more program of CPAP in the new year. We have been having this for last 3 years every month, barring 1 or 2 months during the KCOG or KSOG conference. Today's speaker, the commonality with today's speaker is that both myself and Dr. Shripad Hebbar were students of our patron, Dr. M.G. Hiremat. So we are very thankful to our alma mater, KMC Hubli. That time it was called KMC Hubli, now it is KIMS Hubli. And after that, Dr. Shripad Hebbar had a beautiful journey. He worked for some time in Siddhartha College in Tumkur, and then he joined KMC Manipal, initially in our hospital in Udupi. Then he came to the department. He is one of the most intelligent professors I have seen, very hardworking, very humble, and he is very dear to all his patients and students. He has got umpteen number of awards and publications, and he has proved himself to be a very good administrator as well now. Ever since I left KMC Manipal, he's been the HOD there, and he's been supporting all the fellowships that have been started in the department. He is currently the director for the fellowship in urogynecology and female pelvic medicine and reconstructive surgery, KMC Manipal, in addition to being professor and head of the department of OBG, KMC Manipal. He is the member and past secretary of Manipal OBG Society. He has received Best Teacher Award 3 times, guiding Best Thesis Award twice. He has authored with me the book on PMFU, Obstetrics and Gynecology PMFU, published by Elsevier. He has 80 plus publication, 30 of them in Scopus, PubMed indexed, and 50 in presentations. He has received Best Paper and Poster Publication Award twice, and has received several journals, reviewer of several journals in OBG. He has got the state award in 2021 for performing highest number of surgeries for HIV positive women. Congratulations, Dr. Sripad. He's also been awarded certificate by Federation of Royal College of Obstetrics and Gynecology. Today, he is going to talk on a very important subject, that is respectful maternity care. I heard him give this oration in the last week of December in Manipal, and it was excellent. So that time only I was thinking for the next KCOG CPAP, he must talk about this, because as Dr. Rajeshri said, it is very important that we not only give care, but we give respectful care. Now, many of us may not be aware what is this respectful care. So he has got beautiful slides. He has done extensive research. He has taken references from so many institutions like WHO and even United Nations and everything. So I'm looking forward to listening to it again. So over to you, Dr. Sripad.
So thank you very much, sir, for the kind introduction. First of all, I'm thankful to you for selecting me for this prestigious talk for this particular month. And I'm also thankful to the MGM sir. We are his students. So we have seen him, how he has lectured and he has moderated the students. He's a role model for all of us. And one thing about Dr. Murli and Dr. M.J. Remat, I mean, they are ever, okay? I mean, we can call them as Rajnikant and Amitabh Bachchan of our OBG society. So thank other members of the society. I thank once again, and this talk it is a little bit off the track. It's not much to do with the obstetrics, but I feel like all of us should know about it, because it's a game changer with respect to like how you treat our patients. Most of the time we think them that they are patients. Actually, they are not patients. They are also human beings, and we should give a psychological dimension towards our patient care. So shall I start sharing the screen, sir?
Yeah, please, Hebar, sir.
So screen is visible, sir?
Yes, sir.
Yeah. So
5 weeks, it is less than 5 weeks, no?
Yeah, I request other members to be on a muted mode. Otherwise, sometimes we do not know whether the question is directed to us or to somebody else. So this is the title I gave to my recent oration, that is Empowering Mothers and Promoting Dignity, RMC, that stands for Respectful Maternity Care. I was always thinking when I was appointed earlier as a lecturer at Siddhartha Medical College in Tumkur. That time we didn't have a well-established department. We used to go to the government hospitals, and there I saw like how the sisters were having competitions because they used to work in shifts, 8 to 8, and the day batch it wanted to complete the deliveries in time because sometimes I had seen them giving a lot of oxytocin, applying unnecessary vacuum, just because that time that was a practice. That if you deliver in your time, you are eligible for your some what you call a law that some money from the patients. So they used to charge the patients some 500 rupees and all. So there was a lot of competition, not only to complete the delivery in time, and also there was a lot of competition to get the labor room posting done. And I've seen like how the women were treated, and I always felt that because she's not just the one who gives the birth to the baby, but she's also a human being, and she's also another human being like us. And how we want ourselves to be respected, we also want. I always felt the patient also to be respected. So in today's talk, I'll just cover different aspects of RMC under 5 categories. That is importance of mother, and what is meant by being respectful. Then what is that so-called charter on RMC by institutional and the universal bodies, and what is the ethics of obstetrics, and how the obstetric care has been medicalized in the recent era for the potential gain to the physicians and to the health system. Janani Janma Bhumischa Sargadapi Gariyasi. माँ और मातृभूमि सर्व से भी महान है. Ma and motherland are superior even to the heaven. So that's the way that we respect our mothers, even in the mythology. The other quotes include Matru Devo Bhava. Mother is more revered than the god. Nasti Matru Sama Chaya. Nasti Matru Sama Gatihi. Nasti Matru Sama Runam. Nasti Matru Sama Kappa. Means there is no shadow, there is no shelter, there is no protector like a mother. There is no life giver in this world like a mother. So that's the importance of mother. We should all know. So who is mother? A mother is one who guides you and who inspires you. She helps you to attain your dreams and desire. Wisdom and insight are the part of her way, and her faith in her children brightens her way. How to take this off from the... Yeah. A mother love is forever strong, never changing for all the time. And when her children need her the most, a mother love will shine. There is no love like the mother's love. No stronger bond on the earth like the precious bond that comes from the God to a mother when she gives birth. So there are different aspects of the mothers. She protects, she always takes care, and she's a very powerful person in our life. So what are the different roles played by the mother? She cooks for you. She's a doctor for you. She gives you a secure feeling. And in addition, she's also a teacher for you. The history has produced always the great mothers. Jhansi Lakshmi Bai, our Yashoda Mata, and Indira Gandhi and her son Rajiv Gandhi. You all know that they're all revered persons. We call and address mother in different ways: Ma, Mama, Mom, and mother and Amma. So you can remember, if at all there is God, and if you are able to see the God, it's your mother. She was always there. Every time you cried, when as a baby and you started growing, she jumped with joy when you first stood up on your tender feet and you grew confident. She celebrated with happiness on your first birthday and you had your cake. She bought you new clothes instead of saree for herself. You showed off to your friends. She gave you her savings to buy your bicycle and you rode with the pride. She cooked for your favorite breakfast on the first day to the office. You became independent, and later on, the story slowly changed. She waited at the door at your first salary day, only to see God's blessing. You had already celebrated your the first salary with your friends. She blessed your love marriage when you came home married. She didn't say anything. You shared your love with your spouse, and you ignored your mother. Think for a moment how much she sacrificed for you. The agony and the pain she went through all the years, it was for you and only for you. So give her your time, a bit of your love for that, all she desires. Tell her that you love her and care too, and she is with you no matter where are you. So you have to be respectful to your mother, and in fact, to all the other fellow human beings. We have all the same human beings. You are all human beings. I went in 2015 to Smithsonian Museum in USA, and there I was told that though the blacks, the Negroes, and the whites, they look different, the difference is only at the level of skin. 99.9% of all the genetic materials, whether you are a Negro or whether you're a white person, it's the same. So remember that we all human beings, we have feelings and emotions. We all feel the pain. We all bleed when you are cut. We expect it to be treated with respect at work, at public places, and in the community too. So some quotes. Respect for ourselves guides our morals. Respect for others guides our manners. So said Lawrence Stern. We don't need to share the same opinion as others, but we have to be respect to each other. So the respect, it starts with I. I treat the other people the way I want to be treated. I am considerate of other people. I treat people with civility, courtesy, and dignity. I accept personal differences. I work to solve problems without any violence. I never intentionally ridicule, embarrass, or hurt others. So there are several elements of respectful care. It includes honor, recognition of others, consideration, esteem, being courteous, being reverent, and regard to the other people. So what is culture of respect? We agree to show the respect for all with our words and actions that reflect that we recognize the other persons as human beings. Compassion, kindness, and respect are the very essence of dignified care. We must make sure that these principles are at the heart of everything we do. But what you find in the society, both respectful and disrespectful behavior exists. Common act of respectful care are reported by both the clients and the providers throughout the world. Appropriate maternity care must be respectful and rights-based in order to enhance the access to the skilled care at birth. Care providers can make a difference by promoting women's rights and empowering the woman to give birth with dignity. So I told you there is respectful behavior, there is non-respectful behavior. So what is being respectful? Freedom from discrimination, explanation of procedures and answer to the questions, consent seeking. Whereas the opposite is lack of information about the progress of labor, lack of privacy in the labor room, and verbally abusing the woman in labor. So what is respectful care? Care, C-A-R-E. C stands for effective communication. A stands for positive attitude. R stands for respect for patients and caregivers and staffs. E stands for environment conducive to care and recovery. What are the types of disrespect? Discrimination, stereotyping, harassment, and bullying. All these things you should avoid in the modern society. What is discrimination? With our words and actions, we treat certain individuals or the group differently, whether it is known community or disliked community. If you are a Hindu doctor, a Muslim patient comes, you behave differently. You had a bad experience, one Lambani who stole your things. You always feel all Lambanis are thieves. It is not like that. Okay, so we should not discriminate based on gender, their caste, and their community. What is stereotyping? We give everyone in a certain group the same attributes. So I just know I told you because all Malayalis are the same. That's my feeling, but it's not so. The attributes do not have to be negative. I always feel that, okay, I am a Brahmin, and whenever I want to appoint another person in the department, let him also be a Brahmin. That is not correct. We are all different, even within the groups. We put others in the boxes. So this kind of behavior should be avoided. What is harassment? With the words and action, we make the workplace uncomfortable and hostile for individual and the groups. And sometimes we target. It was a very common practice in the past. There was favoritism, there was groupism, there was casteism. I can take examples of the professors who ridiculed us, who made mockery of us. At the same time, they always targeted us and sometimes hurt us, because always remember, as a teacher, you have to be kind to your student and you should not bring down their career. So as we want to be respected, even the mother has to be respected. So the respectful maternity care is not an option. It's a right of any human individual, whether she's a man or he is a man or woman. Remember, pregnancy is a special occasion. In every country and community worldwide, pregnancy and childbirth are momentous events in the lives of the woman and the families, and represent a time of intense vulnerability. The psychological changes, the hormonal influences on the woman's behavior bring about a deep changes in the woman's. Her immunity as such is lower, and sometimes she is vulnerable for the shouting, and sometimes she can get depressed easily. Remember, it is very easy to insult a pregnant lady. It is very easy to bring down a pregnant woman's morale. Access to the skilled healthcare during pregnancy and childbirth is important, and the quality of such care is very, very crucial. Pregnancy can be a fearful event. Unfortunately, too often pregnant women seeking maternity care receive varying degrees of ill treatment, ranging from subtle respect to the outright abuse. Evidence is now emerging that this fear of being badly treated and abused in the health facility is holding the woman back from seeking help. So, we had one conference. A doctor from Netherlands came and he was telling now the obstetric practice is slowly going back to the midwives, because the midwives, they are very, very respectful to the women. They respect them. They go to their houses, and in fact, when the midwives conducted the delivery, almost they could achieve 90% vaginal delivery. Whereas when the group was coming to the hospital, always the cesarean rate was around 60 to 70%, because they induce some kind of fear in the patient that this thing can happen, that thing can happen, this can happen to your baby when you are going the trial of labor. And somehow she was motivated for cesarean delivery. Remember, women's memories of the childbearing experience stay with them for a lifetime. That's what initially we heard from our convener. So ensuring safe motherhood is the essence of the time. The concept of safe motherhood should be explained beyond the prevention of morbidity and mortality. We as doctors, we are very much tech savvy. Always we think about mortality and morbidity, and we do not think about the third dimension of the woman, that is her psychological status. It should encompass the respect for women's basic human rights, including respect for women's autonomy, dignity, feelings, choices, and preferences, such as having a companion wherever possible. So, RMC, the respectful maternity care, is a universal human right that is due to every childbearing woman in every health system around the world, and it is aimed at preventing the disrespect and abuse in the maternity care. It focuses on the interpersonal aspect of maternity care. It is centered on the individual and based on principles of ethics and respect for human rights. So the RMC demonstrates respect for a woman's right, choices, and dignity. It is not that you are going to give her a choice. She is going to select what she wants. The RMC is a care that does not cause any harm to the pregnant lady. The care that promotes the positive parenting and improves birth outcomes. The care that is culturally sensitive and valued by the woman and her community. This has RMC has a very long historical background. In 1970, in Canada and USA, there was a movement for humanization of childbirth by midwives and doctors. You all know that in animal husbandry, in the forest, the animals also deliver. So we are not animals, you are human beings. So the labor in humans should be done in a respectful manner, not as an ordinary event. In Brazil in 1975, there was a birth of humanizing childbirth movement. In 1996 in USA, mother-friendly childbirth initiative began. In 2000 in Brazil, there was the first international conference on humanizing childbirth. Again, in 2010, United States Agency for International Development, that is USAID, supported the landscape study by Browser and Hill categories of disrespect and abuse which were identified. So in today's talk, what I'm going to talk is mainly based on the findings of Browser and Hill, the 7 categories of disrespect. And this disrespect is not only a woman can have one type of respect or sometimes a combination of the same. Much contribution has been done by what is called as a White Ribbon Alliance in 2011. So they developed the 7 charters of RMC rights. RMC survey in 2012 by Maternity and Child Health Integrated Program began, and they said that all the labor rooms outside their labor ward, they should display what are this kind of disrespect and how the woman should be treated in labor. So the RMC is founded on the premise that the woman should be well treated during the childbirth. So this is a timeline of event. We'll not go into the details. So all are available. There are plenty of information available in the net. So we'll just concentrate on the different charters of respectful maternity care. So these charters encompasses the universal rights of the childbearing woman, which demonstrate the legitimate place of maternal health rights in the broader context of human rights. So 7 rights have been drawn from the 7 categories of disrespect and abuse identified Browser and Hill 2010. Disrespect and abuse is any form of inhumane treatment or uncaring behavior towards a woman during labor and delivery. So RMC applies to every mother in this world. All childbearing women need and deserve a respectful maternity care and protection. This includes special care to protect the mother, not only the mother, even the baby. So this is called a mother-baby pair, and women who are in a context of marginalization or heightened vulnerability. For example, adolescent pregnancies, ethnic minorities, and the women living with physical and mental disabilities or retropositive status. Tackling disrespectful and abuse. What are these 7 rights of childbearing women? These rights are drawn from the categories which I already told you from the study of Browser and Hill on their landscape analysis. All these rights are grounded in international or multinational human rights instruments, including Universal Declaration of Human Rights, Universal Declaration of Bioethics and Human Rights, International Convention on Elimination of All Forms of Discrimination Against Women. So these are the 7 categories of disrespectful care, physical abuse, non-consented care, non-confidential care, non-dignified care, discrimination based on specific attributes, abandonment or denial of the care, and detention in facilities. And each charter will go into little bit depth. So this is the chart which I was referring to. This should be displayed in all the labor room outside, and so that the patient understands, so what are her rights. It is understood that disrespect and the abuse often fall into more than one category. So the categories are not intended to be mutually exclusive. They should be seen as overlapping along a continuum. It is not says that only the woman is subjected to disrespect or abuse with one particular charter. She can have combination of charter, and sometimes all the 7 may be applicable to a single woman. So these charters are also referred to as articles. So there are articles 1 to 7. So postgraduates sometimes in their recent advances or in the social obstetrics, they can be asked about these different articles of disrespectful maternity care. So the article 1, it states that every woman has a right to be free from harm and ill treatment. So how to understand these different charters? So each one I have a narrative. So we'll go to a different stories, so which supports these hypotheses. Story number 1, the operating room was chilly on a grey morning in Bihar, in northern India. Mrs. SD was spread on the operating table like a martyr, arms wide, but she wasn't dead. She was active and feeling in pain. Throughout her cesarean section, she responded to each incision, each stitch, jerking her face away and moaning. That means that it was a suboptimal epidural or spinal anesthesia. Many times it is a practice by the anesthetist because he wants the patient to be shifted immediately after the anesthesia so that he can attend next case. So what they do
He
is,
know how to swim ಮುಂದೆ ಅವನಿಗೆ swimming ಗೊತ್ತಾ.
so what they do is they give the little bit less than what is required so the patient can immediately come out of the anesthesia. But sometimes what happens is the dose what is administered is less, and many times, like you go ahead with the cesarean section, though she is having pain. This is not right. The doctors working on the abdomen, distracted by the pulling out of the baby and answering to a phone call and ignore her rise. Because for us, like for her, it's a fresh pregnancy, yes, or it may be a first experience. For her, it's a day-to-day practice. So we many times when you go to the LT, we find the woman crying, woman shouting, woman screaming, but we just are thick-skinned towards her feelings. So the cover, the drape was ineffective. The doctor pumped SD full of pain medication during the surgery, and he said that she was moaning out of fear. She, however, blatantly disagreed. I remember that I was shouting out of pain. Whenever she moaned, the doctor shook her, he jerked her, and he finally hit her over and over during the surgery. There have been a bad habit of the surgeons. Sometimes I have seen surgeons hitting their assistant on their knuckles, but I have also seen the surgeons sometimes, traumatize the patient. Recently, I heard a story wherein a doctor in UK, he was a very famous liver surgeon. Every liver surgery he did, at the end, he used to carve his name on the liver. He used to do a cautery on the liver of the patient, writing that, okay, he is operating surgeon and his name. So later on, he was subjected to trial and he was removed from his medical registration was taken off. Her lips snailed and he looked angry at the disturbance. There was no concept of her cries representing a physical need or something wrong with the pain control. They are only annoying. Mrs. SD abdomen still open, half anesthetized, uterus exposed, had no choice but to weather the health workers' blows. So that means that she was operated under suboptimal anesthesia. So which is most of the time is true. So what article number 1 states? No one should physically abuse the pregnant lady. All physical contact with the pregnant woman should be as gentle as possible, comforting and reassuring as possible. Even though freedom from the physical abuse is the right of each patient, there are many stories of physical abuse that take place during the childbirth. So what are the examples of physical abuse? Being pinched and slapped. That means you are pinching the patient, you are slapping the patient. Most of the time you have seen the sisters beating the patients. Being restrained or tied down during the labor. Undergoing unnecessary and extensive episiotomy. We all know sometimes, like if you wait, the baby will come out, especially for a multigravida, grand multigravida. But what you do is you want the baby to come out fast. And we think that by giving episiotomy, we can quickly achieve the labor. And sometimes it is because of financial gain. Suturing of vaginal tears and episiotomy cuts without the use of anesthesia, telling that there is not enough availability of anesthetic drugs. Being subjected to pushing on the abdomen to force the baby out or excessive physical force to pull the baby. I've seen people giving unnecessary fundal pressure. I've seen the people trying to extract the baby before the head is completed the mechanism of labor, causing shoulder dystocia and so on. So we'll come to the next article. That is article number 2. It states that every woman has a right to information, informed consent and refusal, and respect for her choices and preferences, including the companionship during the maternity care. So we'll go through the story. By 37 weeks into her pregnancy, Mrs. KM, pregnant with twins, developed edema of the limbs that spread to her whole body. KM was also receiving antenatal care at a private clinic, had repeatedly requested that she should be referred to a tertiary facility where equipment specialists would be more readily available because she had an obstetric complication. The doctor in the clinic ignored her wishes, and she did not have the confidence to insist on a referral. KM soon developed severe preeclampsia, was admitted to the hospital. The doctor informed Mrs. KM that she would operate, giving her little or no information about her condition and telling why she requires the surgery. Just I wanted to tell it was a case of severe preeclampsia with one of the organ dysfunction. The doctor insisted that there were no complications, though he knew that inside it is a case of severe preeclampsia. When the patient requested for a referral, he became furious and he threatened to write a referral in such a way that she will not get any help even at the tertiary center. KM's mother started crying in anger on visiting the hospital. You are forcing my daughter to remain here, even if she will die, as long as you will get your money. No one listened to her. She underwent emergency cesarean section. She had a severe postpartum hemorrhage on the table, and finally she succumbed. So she could not be resuscitated as surgical expertise, and the massive transfusion protocol was not available in this hospital. So nowadays, they say that whenever you have got an obstetric unit, you should have facility for the blood transfusion. I remember recently, one of the doctor was heavily penalized. The hysterectomy was done. Patient had some problem, but there was a requirement of ICU, and ICU was not there. And based on this, though everything was done, because there was no ICU, there was a heavy compensation which was ordered. So nowadays they say that if you do not have a surgical expertise, you don't have a cross-referral facilities, you do not have a blood bank backup, you don't have an ICU backup. Okay, so you have to be a little bit careful when you are managing high-risk pregnancies or any other cases for that matter. So the article number 2 states that no one can force you or do things to you without your knowledge and consent. If the patient says that I want to go to a different hospital, you don't have any It is all patient decision. She can choose her doctor. We don't have any right to choose the patient. All patients need a careful explanation of proposed procedures in a language and at a level that can understand so that they knowingly consent or to refuse a procedure. This is what is called as informed consent. So the patient has the right, finally, if she says, I don't want to undergo this particular procedure, you have to either convince her to undergo a procedure or you have to refer to a facility where she, okay, you are not, sometimes you are not comfortable because she refuses the consent. So you have to refer to us another center so where she can receive more counseling. So what are the examples of non-consented care? Not giving the woman the proper information about the medical procedures, what you are going to do on her. In fact, in our hospital, even for episiotomy, we take the consent. Not asking the woman permission to conduct surgical procedure, such as induction and augmentation of labor. Many people, like they just start the oxytocin drip. The patient does not know what is going on, what drug has been added, but you have to inform the patient. Performing unnecessary episiotomies, cesarean sections, and even during sterilization. I've seen sometimes, the doctors, the patient does not listen to her. She wants to have more babies. The doctor takes the decision. This is what is called when you're taking the decision on the patient's part, it's called a parenting. It is called a parenting attitude. I've seen doctors who forcefully cut the tube because they cannot document that the patient has to undergo sterilization. So see that they crush the tube and eventually the patient becomes sterile. So even giving unnecessary blood transfusion, it is clearly stated that unless in a case of postpartum hemorrhage, unless the hemoglobin is less than 8 grams, sometimes you can manage a conservative. So the preoperative hemoglobin was, before delivery, it was 13 grams. Now she might have had a 500 ml blood loss. Now it is 12 grams. It doesn't mean that you have to give blood transfusion just to tackle that 500 ml blood loss because she was already having a good hemoglobin. Most of these things are not done purposely in the institution, but I heard in some of the this one, that nursing homes unnecessary intervention takes place. So we'll come to the article number 3. Okay, every human has a right to privacy and confidentiality. That means she can demand privacy and confidentiality. So what is the story suggests that a young woman was giving a birth in labor ward in a busy municipal hospital in Mumbai. The labor ward was like a hall where each woman could see what is happening to the other peers in the next bed. So after the initiation Lakshya program, I heard even in the government hospitals, each patient will have some kind of privacy. There will be curtains. When you have students and all, no, so it was difficult because there was the number of people who are entering the labor room were more than the number of beds available. So sometimes you have to conduct keeping them all together. Sometimes the one woman can see what has happened to the other woman. Senior doctors, nurses, students, laboratory technicians, and others filled in this open hall, and the young woman knew that they would all see her naked. So for us, it may be a common scene, but for a woman, like when she lies naked in front of unknown people, her privacy is in danger. The people cleaning the ward could see the deliveries. The ward boys could see the deliveries. So definitely it is not acceptable in the modern obstetrics. The medical attendant instructed the woman to open her legs because she was due to push. That's all we do. When the patient is pushing, we'll tell them, okay, keep your right leg apart. But the young woman held her legs very closely and tightly because she is shy. And you know that some of them, they'll have what is called vaginismus and the environment is not very friendly. In a panic, the medical attendant shouted, open your legs just as you did when you were conceiving. Okay, this is demeaning to the patient. You all know that how we are born, what parent have to do for our birth, but that is immaterial. So that we'll not think about those things. We'll think about that is the way that we all, the human beings, they reproduce, the offsprings are born, and the world sustains. Okay, so we humans live on this earth. So we should not tell the bad words like, okay, it is easy for you to get you pregnant with your boyfriend. That time you opened your legs. Now are you not able to open? So these kind of comments are very bad. And if the patient can always file you a case telling that you disrespected her, this can be what is called as violence against the woman in the working place. So in tears, the woman closed her legs even tighter, and the attendant reacted with a obstetric slap on the thigh. So many times, we see that the patient is not opening her legs, so we slap on the thigh. This is not acceptable. These things made the things still worse because the young woman would not let her privacy to be violated. She closed her legs still tighter further. She and the baby were getting distressed. Another health worker was consulted because nobody could make her cooperative. This particular woman was very nice, spoke to the young woman in a more polite and professional way, and finally the baby was delivered through a vacuum extraction. So what I want to tell you that you may be from a very good medical college, you may be having a tons of knowledge, but if you do not have a polite behavior, the woman definitely will not accept you as a good doctor. Remember, most of the good doctors in the obstetrics, in the field of obstetrics, they are not very knowledgeable. They are not what you call the encyclopedia of obstetrics. But the successful one are those who are very polite and who are very, very professional in managing the these kind of women. So what is the Indian labor room scenario? In India, husbands and partners are not allowed in the labor ward because of overcrowding and the lack of privacy. Definitely, if my wife is undergoing delivery, I do not want another person to see it. So this lack of privacy is a violation of woman's basic right as human beings. In abroad and all, when the woman is undergoing delivery, so it will be in a separate suite and the husband is allowed inside. So because when you do not conduct the labor in a privacy, no woman would like to be seen as naked and to be exposed to the another nakedness when she is undergoing a labor ward for maternity care. This is very, very demeaning. So what does the article number 3 says? No one can expose you or your personal information. Dr. Pratap always used to say, never ever discuss the personal things of the patient on the corridor, within the lift. Many times, say, no, okay, the Kusuma, okay, she is retropositive. Sometimes you say, oh, that donor egg IVF pregnancy, is it so? So sometimes you pass on loose comments. So that is not correct. So you have to be very, very confidential. In fact, nowadays, the teaching the patient by the bedside is also questioned. Many times, when you're discussing a case, let us say preeclampsia, you say there are several n number of complications, and finally say if preeclampsia can cause death to the mother and to the fetus. The woman will get depressed if she is able to interpret what you are telling. So you should be it's very, very important that when you are conducting a bedside clinic, don't discuss the complications. Okay, you are there to demonstrate the clinical examination. In fact, it is ideal that once the clinical examination is done, you take out the patient from that area, or you go to a different area wherein you can all sit together and discuss, and the complication the patient should not hear about. So the doctor must do everything possible to protect the privacy and confidentiality of the patient and their information. For example, privacy and confidentiality during the history taking, physical examination, clinical procedure, and counseling, when handling the patient's medical records and the other personal information. Examples of violation of privacy and confidentiality include having to labor and deliver in the view of others, that is without privacy barriers such as curtains, having healthcare workers to share sensitive information such as patient HIV status, marital status, sometimes it can be an unwed mother, medical history, in a way that other patients and other people can hear. We'll come to the article number 4. Article 4 states that every human has the right to be treated with dignity and respect. Mrs. UA, 35 years old, and she lives in Bangalore. She is a highly educated lady with a master's degree. Unfortunately, her resolve and strength were tested during the third pregnancy. It's her story. I visited the doctor at the time of delivery. The pain increased on the second day. And when I went to the hospital, the doctors told me that I would give birth within 2 hours. So initially, she was informed that she's going to deliver within 2 hours. She was also asked to walk in the corridors of the hospital to facilitate the process of childbirth, which we all do. But the problem was she underwent multiple vaginal examination, but she was not delivering. She states, I decided to return to my house because she's not delivering, but was confronted by the first doctor who screamed at her, telling that if you go home, we are not going to take this, and we are not going to take any responsibility what happens at home. She says, I was in pain, not just the pain of childbirth, but the pain of various tests and per vaginal examination. The doctor who also screamed at another, she saw the same doctor was screaming at another woman in the delivery room and who was bleeding and crying and tried to tell the doctor about her situation. So in this scenario, after witnessing how the doctor behaved, she says that I was totally exhausted and fatigued by this time. I decided to change the doctor, and she changed the unit. And fortunately, the other unit doctor came and attended to her very in a short time. And she says, I cannot help but compare her kind treatment with the cold, disinterested treatment I had received in the hospital from another doctor. She provided me emotional support and took a genuine interest in me. She did not leave me alone and ignore me, unlike other doctors in the hospital. She was kind and patient with me, even when I was screaming during my final stages of labor. So that means that definitely there can be two types of obstetrician. One is kind-hearted, the other one is not bothering. So the article number 4 states that no one can humiliate or verbally abuse you. Examples of non-dignified care includes use of harsh tone, harsh language, unkind expression, dirty language, so-called non-veg jokes, abusive words on women, screaming and shouting on the woman. These things are not acceptable in the modern day obstetric practice. We'll come to the article number 5. It states that every woman has the right to equality, freedom from discrimination, and equitable care. This is the story from Africa. Mrs. N moved to Kinshasa to pursue her education. She got married and became pregnant. Her husband was unemployed. Most of the third world countries, like it is the woman who works, husbands are unemployed. So she could not afford a good antenatal health care. When her baby was due, she went to the closest health facility and spoke with the nurse at the door. Did you have antenatal visits here? Asked the nurse. So nurse she was an unbooked case for that particular hospital. No, answered the patient. How much money you have? Asked the nurse. She said 2,000 Congolese francs. So remember, 2,000 Congolese, it will look big money. It is only 2 pounds. Patient states, I used the extra money. I had to come here. Replied the Mrs. N. Your case cannot be treated here. Continued the nurse. Go to the general hospital in Kinshasa. So this is most of the time, like in the private hospital, when the patient comes, the doctor comes to know that patient does not have money. Then they'll say, go to the general hospital. She went to the hospital with her older sister, but was again asked how much money she has. Okay. And she was again turned away. She was told to go to another hospital called a Bondek hospital, which was 5 kilometers away. Despite her pleas for help, she had to make her own way to Bondek hospital, where she died at the door of the labor room. So that means that the patient visited multiple doctors. Every time she was turned out because she didn't have a funny, and finally she lost her life. Another instance, a Kenyan woman who had given birth as a teenager in a maternity recalls that the nurse would tell her young teenage mother, you young girl, what are you looking for a man? Now you cannot even give birth. Okay, so this is how they tease the young woman. In some areas of Sierra Leone, in Africa, it is believed that obstructed labor is caused by infidelity, which may result in caregiving, the blaming the condition on a woman's past behavior, insisting that she confesses, and addressing the immoral behavior instead of focusing on the healthcare situation at that particular time. So that means that whenever there is the infidelity, whenever the unwed mother is there and she's going to give birth, and many times she's not looked after well by the other the doctors. So they say that in US, like, okay, she can have multiple partners. It's none of your right. Okay, so we don't have to comment on her the past behavior. Now currently she is pregnant. She has come to you for delivery, and you have to address just that part. You should not never dig the past history. So what the article number 5 states: no one can discriminate because something they do not like about you. All women are equal and must be treated with respectful care, regardless of their ethical background, culture, and social standing, education level, and economic status. Examples of discrimination during childbirth may be based on a woman's race, ethnicity, language, HIV status, traditional beliefs and preferences, economic status, and educational level. The last 2 articles, article number 6, every woman has a right to timely health care and to the highest attainable level of health. Okay, this is whether she is poor, whether she is affordable or not, she has the right for the highest level of health care. This is another story from Dominican Republic. Mrs. OM was 29 years old when she died after having a normal birth in the early morning hours of October 20, 2005. She was already in rigor mortis when a relative found her during hospital visiting hours that is between 2 to 6 p.m. So that means that the patient had delivery. She was shifted to the ward. She was within the blankets. There she had PPH, and patient was under shock. She could not call anybody for help, and finally she died. So the patient died from a hypovolemic shock due to the postpartum hemorrhage. I still remember it also happened during my PG days. One of the post-hysterectomy patient was in the ward. Uh, Most of the corresponding PG was given the ward in charge. He never used to see the patient. He used to simply write, sit by the chair away from the patient. He's write vitals fair, but BP is okay, this one is okay, uterus is well contracted, she is conscious, well oriented and all. And during the rounds, she was found to be dead because that particular postgraduate never bothered to see the patient in person, and she was dead by that time when the round started already. It was 2 hours more. The doctors and the nurses never checked the patient in immediate postpartum period. This is not right. There is something called as the fourth stage of labor. All the women should be watched. And remember, postpartum hemorrhage can occur anytime, especially in the first 24 hours, and the patient should not be left unattended. She had been completely wrapped up because the patient in shock really feel cold, and no one realized that her condition, nor did they investigate. So said the Sula Miller, the famous writer, this instance came to her and she describes it. So she says, when I heard this story, I broke down crying, never again. This is the most preventable death I have ever heard of. There was no reason outside the gross negligence and lack of attention to the humans and woman's right and the dignity that should have bled to death alone in a big city hospital with hundreds of staff. So this is definitely not acceptable. So the article number 6 states that no one can prevent you from getting the maternity care you need. A woman who is in labor or has just given birth should never be left alone. At health facilities, the woman should be able to have a companion of her choice, such as a family member with whom throughout the labor they can stay and birth to provide continuous support. So this is acceptable and it is a practice in US, but still it has not come to India. What are the examples? I think some of the hospitals in Bangalore, like Cloud9 and all, they allow the husband to stay with the wife. I'm not very sure. In Manipal, still this is not in practice. What are the examples of abandonment? Women at facility being left alone during labor and not receiving any medical attention. I've seen many times, they write in the record, patient is 2 centimeter dilated. And after another 3 hours, they write that patient is fully dilated. So what has happened now? The patient never was observed between 2 to 10 centimeters. Okay, I've seen the patient being received from the ward with a fully dilated cervix. So this is definitely a negligence in an institution. Women giving birth by themselves, not having patients to assist them. Many times you have seen, like the women, they deliver in the ambulance, the woman's deliver in the enema room. That is not acceptable. Woman being allowed to bring a companion in the birthing area. She is not allowed to bring her partner. Providers failing to monitor a woman in labor and intervene in life-threatening situations. We'll come to the last article. The article number 7 states that every woman has a right to liberty, autonomy, and self-determination and freedom from coercion. A short story. We have all seen the various women in our hospital who, after delivery, remain in the ward for days and weeks because they are yet to settle the hospital bills. Recently, it happened in Delhi hospital where the baby remained in the NICU for 3 months because you know that NICU bills are in lakhs because she could not settle the bills. Finally, the government intervened and the baby got discharged from the NICU. The NICU didn't want to discharge the baby because the patient did not clear the bill. So the article number 7 states that no one can detain you or your baby without legal authority. It's okay. 1 out of 10 patients may not pay you, but still okay. You have to think that you are doing a social service. Some health facilities have been known to detain or prevent women from living with their babies because they cannot pay the hospital bills. This is usually only for a day or two, but there are reports of patients being held for weeks and months, as I stated earlier. Even the women whose babies have died are detained because they could not pay the bill. So you know that some of the hospitals, they are not ready to, it happened during the COVID time because the hospitals are not, especially the corporate hospital, they are not ready to release the body because the bills are not paid. So what some inferences you can draw from these articles and the stories? When a woman experiences disrespect and abuse during the facility-based care, her rights are being violated. Often when this happens, more than one of her 7 rights are being violated at the same time. As I told you earlier in the beginning of the talk, around the world, in both wealthy and poor communities and the countries, women have been and are experiencing disrespectful care and abuse. All women deserve respectful and dignified care during pregnancy and childbirth. So ethics of obstetrics, I'll just skip on because I'm nearing 1 hour. I'll just talk about what is this medicalization of obstetric care. So medicalization, what is it all about? We use the term medicalization to describe the process by which a behavior, natural phenomena, or aspect of human condition becomes to be identified as a pathology which requires medical study, intervention, and surveillance. I always tell my undergraduates and postgraduates, patient who is pregnant should not be called as a patient. She's not a patient. Patient means she has a disease. Pregnancy is a physiological status. She is another woman. She is a pregnant woman. She is not a pregnant patient. But what has happened is, just because woman becomes pregnant, she is labeled as patient. So the routine, what is medicalization of obstetric and newborn care? The routine is of practices during labor and childbirth that are not evidence-based, are unnecessary and unwarranted, are unfamiliar, often undesirable to the woman, do not improve the health outcome for mother or the baby, or sometimes they do more harm. Prioritize the need for providers over the need of the woman. Encourage technology or intervention without proven benefit. Many times, like people say that, okay, I'm going to give a painless labor. So is it really? Sometimes it may not be having a proven definite benefit. Sometimes I've seen, like the patients asking for epidural analgesia when finally ending up in not pushing and going for the instrumental deliveries. But why you behave like that? As doctors, we have got medical legal pressures. Sometimes you do it for profit. Non-evidence-based beliefs within the medical communities and established practices, convenience for providers, because I heard recently one doctor in Kerala was going on a leave. It was a weekend. There were 13 patients in the ward, but Friday and Saturday he wanted Friday and Saturday and Sunday he wanted to take leave. What he did cesarean for all the 14 patients who were in labor, and he left the facility. But later on, it came to the notice of the newspapers, and the doctor was not terminated. He was transferred to some other health center. So sometimes, we give the patient illusion of safety, which is not really so. And sometimes you induce the fever so that we can control the birth. Like we can motivate the patient instead of going for vaginal delivery and going for cesarean. So why does medicalization matter? The cost can be higher. You all know that normal vaginal delivery is cheaper than the cesarean delivery. It can reduce the access to the intervention for those who really need them. So in the government hospitals, you know that there is a long queue and you have to prioritize who has to go for cesarean and who has to go for vaginal delivery. So you have to minimize the wastage of resources. Can lead to poor health outcomes. I have seen the cesarean rates in some of the nursing homes going up to 99%. Do not involve the woman fully in decision making and results in her discomfort and disempowerment. So this is what is sometimes, like offering the patient the cesarean delivery without she asking for it can amount to disrespectful care. So the practices that can be proved harmful are restricting the ambulation and different position during labor and choice of birth position, lack of companion and family during the labor, overuse of anesthesia or analgesia, administration of oxytocin at any time before the delivery in such a way that the effect cannot be controlled. I've seen that oxytocin being given intramuscularly so that the patient expels in short time. This is not correct. Restricting the food and fluid, thinking that if she takes food, I cannot do immediate cesarean section. Unnecessarily, I have to wait for NPO status. Routine episiotomy, early cord clamping, separation of mothers and the baby. They're all what is called as harmful practices according to the recent literature. Again, there is a big question about what is called an unnecessary episiotomy and routine episiotomy. Episiotomy can reduce the maternal and neonatal morbidity only if they are restricted to evidence-based indications. So there are several indications you have to follow when you're giving episiotomy. Sometimes some hospitals, they give universal episiotomy, whether she is a multigravida or a grand multigravida. Even for sometimes, like for a faster delivery, with just setting up the perineum is enough. It is an average size baby, but people still want to give episiotomy. And episiotomy, remember, when you give it unnecessarily and repeatedly, it can cause associated morbidity such as perineal damage, tears, pain, and dyspareunia. So they say that nowadays, if at all you want to give episiotomy, it should be a restrictive episiotomy. Another thing is that the choice of birth position. We obstetrician, we always think that woman can be delivered only in dorsal or lithotomy position. Remember that the lithotomy position for not actually for labor, it was devised for extracting the stone from the bladder. Remember, woman can better deliver even in a sitting position, in a squatting position, because when she is under a squatting position, there is something what is called a gravity acting upon it adds to the power of the uterus. So remember, gravity is the greatest aid in giving birth. But for historical and cultural reasons, we make the woman birth giving the dorsal position or the lithotomy position. Choice of position for labor and the birth encourages a woman's sense of control and reduce the need for analgesia. What they say is when the woman delivers in a squatting position, I really don't know, okay, because this is what is said, and there are people in the abroad, especially in the European countries, who deliver. I have seen the videos also. They deliver in a squatting position like that, but it's very. We are not used to this kind of deliveries, but this kind of deliveries they are practicing nowadays. Okay, so randomized control trials have stated that women who exhibited a non-supine position had a fewer perineal injuries, had less vulval edema, and had less blood loss. It seems that this particular position, which I am showing on the right side, has a better obstetric outcome rather than on the lithotomy position. Okay, so non-supine position has a shorter period of second stages, require less pain medications, and there are few abnormal fetal heart rates. I do not really know like how to apply the NST belt in this particular position, but they say that this is the best birthing positions. Okay, so they say that there is a lot of scandals that took place even in abroad. So the doctors did unnecessary cesarean sections, whereas there's another group when they went to the midwives, they had a larger number of vaginal deliveries. We'll not go into the details because of the paucity of time. So nowadays, everybody says we should achieve as much as normal birth. We should campaign for normal birth. The WHO states that you have to keep the cesarean rate around 15%. How can you do that? Number one, wait and see. Get her off the bed. Justify intervention. Listen to her. Be a role model. Be positive. Promote skin-to-skin contact. So provide support persons. The presence of a birth companion, it is said that improves the birth outcome and the overall birth experience. Most of the time when you say it's the birth companion, we think about the husband. Need not be. Okay, even her mother is fine. Her sister is fine. They say that when the relatives are by the side, okay, the patient is, she is comfortable. Okay, so continuous empathetic and physical support is associated with shorter labor, less medication, and fewer operative deliveries. That has been already proved. And another thing is that as soon as the baby is born, we try to take the baby to the NICU. We want to keep the NICU for observation for few hours, sometimes 1 or 2 days. Most of the time, okay, we give some this one, telling that baby has hypoglycemia, baby has got some respiratory problem and all. We okay, even in the corporate hospital and teaching institution nowadays, what is happening is mother and the baby are separated for 24 hours. So this, especially during the cesarean section and all, no, we have seen that the cesarean mother, she'll see the baby after the initial glimpse only after 24 hours. So they say that it is the crime. The day of birth is the most dangerous day for the mother and the baby. So you have to promote warming with skin-to-skin contact after the birth. Remember, the baby is mother's right. The baby has to be kept by the mother so that she can develop bonding. Promote early and exclusive breastfeeding. Ensure mothers counsel on danger signs. So remember, RMC has to be implemented everywhere. Recognition of who are the key stakeholders: pregnant women, families, community, national leaders, healthcare providers, policy makers, training institutions, human rights activities, women's advocates. Advocacy, involvement of community and media. You have to conduct more studies on RMC. So, and you have to get yourself convinced that RMC is a better care than the medicalized, the modern obstetric care. Political will and commitment at all levels to ensure appropriate policies. It is not only the the doctors, even the government, okay, should insist that we should go for RMC, and they should also conduct the training modules for the healthcare workers, mobilize resources to support implementation. So, but why are not able to provide this RMC? Is that we as a obstetrician are guilty? Is it that our hospital system is guilty? Is it that our state or country is guilty? Is it us or the government or the both? So who at fault? Is there any hope for improvement? Remember, we all have a role in assuring that all women have respectful maternity care. So there are definitely benefits of respectful maternity care, respect for belief, tradition, and the cultures, empowerment of women and her families to become active participants in the healthcare, continuous support during the labor, choice of companion during the labor and the birth, the right to information and privacy, freedom of movement during labor, choice of position during the birth, good communication between the client and the providers. Definitely, these all points are promoted with RMC. So, respectful maternity care, RMC, is an opportunity to care for and care about the commitments. It's a challenge to meet and exceed client expectations. It is a chance for us, for everyone, to create the right impression for both clients and the providers. So, respect, we are a community, we make a difference, promote the right to respectful maternity care. So, thank you very much for patient listening. Almost, I spent 1 hour into the computer. I hope those who attended, definitely it was useful to them. This has been recorded. I hope, I feel so. And I request all the members to go through the recordings whenever they are free. I know that you're all busy obstetricians because it is the time for most of the private practitioners to be in their clinic. So thank you very much once again. Thank you, sir, Dr. Murli, sir. I am very elated to see all my teachers, Dr. M.G. Rahmat, and I think some of the colleagues also. So thank you very much for this opportunity to touch upon RMC. I know this is a bit off the track, but I think this will become the essence of obstetric care in future. Thank you very much again.
Yeah, thank you. Thank you very much, Dr. Hebbar. It was indeed excellent talk, I must say, because we give care, but respectful care is definitely different from just giving care. And you have touched upon all pertinent issues, narrating the stories, the real stories that happened, how inadvertently sometimes knowingly also we may be hurting others. It is not only the delivering mothers, but anybody, any patient, we should not hurt them knowingly or unknowingly. And you definitely spoke about all the 4 principles and 7 principles of respectful maternity care. So I hand over the mic to Dr. Rajeshri. If anybody wants any more information on this, or if they have any doubts, if they need any more clarifications, she will handle this. Over to you, Rajesh.
Thank you very much, sir. And thank you, Dr. Shripal Hebbar, sir, for this wonderful and very simple but practical and informative talk, which we all tend to forget over a period of time that although we consider labor as a process which is very natural and normal, we tend to interfere and intervene and cause undue trouble to the patient and to the attenders, etc. Having said that, although since the first childbirth is the norm, but still we are again and again discussing of the aspects of natural phenomenon that is labor birth, because in our attempt to scientifically approach the delivery and the labor care, sometimes we end up doing more harm to the patient than good. And time and again, we need to remind ourselves for the respectful maternity care, as you have told in all your examples and all the points which have been so wonderfully covered, and very simple, practical, yet we fail. And the whole maternity unit has to be taught and trained about the respectful maternity care, because the caring obstetricians are often there to give the instructions and come and monitor once in a while. But those around the patient that is attending staff, the nursing staff and the junior doctors, and especially now what we have the trend of doula care, that is having a trained midwife to be attending the patient, has given great benefit and great uses. And in our endeavor to reduce the cesarean section, I think it is important that we bring in such topic for discussion and sensitize our practitioners that we have to follow this definitely. And I would like to know if there are any questions from the delegates which we can take up, and Dr. Shripad Hebbar would be there to address the gathering. Most of the points have been so very well covered, but I think there's nothing to add. Welcome, Mahesh sir.
Good evening, everyone. And at the outset, I'd like to thank Dr. Shripad Hebbar sir. It was very enlightening and eye-opener lecture, I should say. There's so many things we see routinely in life and, labor wards, but then how sir summarized it, and with each case discussion and each separate cases across the world he brought in front of us and he showed with example. We are really thankful to you, sir, for accepting and being on the forum today. And I thank our Muruganar Pai sir, who is always bringing such nice topics and nice speakers to the forum of CPAP. And thank Muruganar sir, and thank you Rajeshri madam for the question and answer sessions and initiating the discussion. And I thank Dr. M.G. Hiremat sir, the patron, and also all the delegates who took out time to attend and make this a successful session. And the recording will be available and it will help a lot of people going forward. This is a hot topic, and Dr. Shripad sir is the one person who could do good justice to this. And we again thank you, sir, and thank you all.
If there are no questions, yes, Dr. Sonia Mandapa has something to ask.
Madam, a wonderful topic. I was always wondering what would sir talk about this topic actually. But then after listening to this, I feel that we should have one session for last day of the postings, undergraduates and gynec department. One day exclusively dedicated talk on this particular topic, I feel, ma'am.
Anyways,
Correct.
this is there on the YouTube now. So Sonia, you can show it to your students.
Yes,
I
sir.
agree with you. I agree with you. That's why he gave this as a oration, Professor Krishnan with the oration last month in Manipal. I was highly impressed because we talk so many things about medical aspects, but we lose out on these aspects. So that's why it is important.
Sir, one thing
Yes,
I
sir.
don't know if I missed out. One thing to add on is the gadgets what they carry, either the postgraduates, or the nursing staff, or the housekeeping. They should not be allowed to click pictures or videos when
Yes.
there is a procedure which is happening, which may
True.
go viral. This was an issue earlier also sometime. So
You
I think
you have raised a very pertinent issue. Very
Yes.
correct.
Yes, sir. Thank you
Many
so
of-
much,
Yeah.
sir.
And,
Muralidhar, sir. Thank you so
Yeah.
and
much.
one thing
Happy
I
New Year
want to
to all.
suggest, sir.
Yes, ma'am.
Veeda madam.
One thing, it was a very good talk, Dr. Shripad, but it should reach the paramedical staff also and the entire maternity team,
Yes.
not only the doctors.
Yes,
Yes.
ma'am.
Because so many times the doctor will be polite and the nurses will be shouting,
True.
hang madbeda, hing madbeda. So it should reach the entire team of maternity, what you call labor room or anywhere. And the paramedical workers, health workers, everybody it should reach. Most of the time, they will be talking, abusing more than the doctors. That's what I have observed.
Yes,
Correct.
madam. For this reason only, I must add on that the manyata which we are doing, the first line is respectful maternal care. This is actually incorporated in the syllabus of that for nursing care. As you said, the paramedics, other than nursing care, also should be knowing about it.
True. Yes.
So,
I
Dr.
think
Shripad, that is lots of compliments for you. I'm very happy that you chose this. It was selected by him only, and that's why I thought this should reach a wider audience, and it will be there on YouTube anyway. And hopefully, Manyata also can use this talk. to while teaching the paramedics.
Yes, sir. Thank you. Thank you so
Thank
much,
you
sir.
very
Thank you, madam. Rajashri, madam.
Thank you, Sonia. Thank you.
And my
Thank
one
you,
comment,
Muralidhar, sir.
sir, because what I found is we are doctors are scared, and recently Amit Shah has bought a bill. There are, in fact, there are bills to protect doctors, but most of the time, that angry crowd, angry mob, they vandalize it or no, you lose your moral. So what I feel is like whenever there is a trial of labor, that all trial of labors need not be successful. See, when you want to achieve the vaginal delivery at 85%, like you have to accept one out of this, some shoulder dystocia, some nerve palsy, or some birth asphyxia. It will happen, but it will not happen for every case. It may be 1 out of 1,000 cases or 1 out of 100. But if you want to achieve this so-called the highest possible vaginal delivery rates, and you have to respect the woman, you have to be the system also should support us. Most of the time, like they even what I feel is the government also does not give adequate protection.
Yeah.
So then what happens is it becomes too much of defensive practice, because finally, when it comes to the question of survival, first thing is you have to save your skin. So, but we should lose this fear. So that is possible only when the society supports us, the mob supports us, and the government supports us. And
Yes.
definitely, no doctor will have a criminal intention of causing any harm. No doctor would like to have a death on the table because of the PPH. We are not criminals, but sometimes we are picturized as criminals because sometimes social media, WhatsApp group. I see sometimes, that very bad comments telling that the doctor cut the nerve, the doctor cut the artery. Which doctor will cut the artery or this one? Okay, but so it's very easy to demoralize. We are all human beings, and you also can come under the stress. And that there are several instances wherein very busy doctors, very good doctors, we have lost them because finally they came under stress and they gave their life. So I think all this respectful maternity care and all, it's not just the stake of doctors, it's not just the care, it's the stake of healthcare givers. It is the responsibility of the entire country. The political will should be there, and all should support us. So if they are for us, we are also for the community, and we are for the society.
Perfect.
True. Thank you so much, sir.
Yeah.
That was a very good compiled message that you have given us at the end of the talk for lasting 1 hour, 10 minutes. And I think all of us are quite sensitized to this aspect. Thank you, Muralidhar, sir, for bringing in this topic and selecting a wonderful speaker for this. And Dr. Hebbar, sir, no words to explain or express what concern you have about the respectful maternity care. Thank you, Sonia. Thank you, Veena. And thanks, everybody, for being there on the forum today.